Good morning, everyone. We have Tim Flynn with us today. I don't really need to spend a long time telling you who he is because you know of him as a world-renowned researcher, speaker, clinician, and teacher. So without further ado, welcome, Tim. Thank you for being with us. And I just want to start off by asking you about AOMT and your involvement in AOMT. So from the beginning, can you tell us the impact and role it's played for you in your profession?
First and foremost, thank you guys for having me on. It's a little overcast here in Colorado this morning, but life is good. So you start out with very light questions on this video cast. So thanks for the easy ones to kick it off. Actually, I got involved in AOMT in the 90s. I think I was at the second. I don't think I was at the first AOMT conference. I think it was the second one I went to, but it was a great time because it was kind of when I was at a bifurcation point of coming out of a PhD, being extremely manual therapy focused, and then going in a PhD that had very little to do with manual therapy. And I was also at this time reading a lot of science, and of course the big evidence-based practice push was happening. And at that time it was this really the stool of EBP was all about evidence, and it was everybody saying, manual therapy has no use in the world, nothing works in the management of back pain, you guys suck, that kind of thing. That was what at least the interpretation coming out of the mid-90s was. For me, the pendulum, I was so skeptical then that I couldn't really function, I guess, in some respects as a clinician. So AOMT was a welcome place to be, and it was just at a time where there's still more camps were involved. I guess what I mean by that is there are different schools of thought that were still in jousting matches about what the right way was, when we were probably arguing about the wrong things. But the beauty of it, we were all very passionate about it, and people cared about the practice and cared about their profession. So it was not negative. It was actually any time you have people that are very passionate, they care, and that clearly is what AOMT was and continues to be. So that really was the beginning of it. I was still in the military, so we were doing research. So I got involved in the research committee and chaired that for a bit, and then some other volunteer stuff, and then took a stint as president when I got out of the Army for a bit.
Tim, I remember you were president, and we had our meeting was in Seattle, and Richard Dayo was one of the presenters. And I just remember, they talked a lot about kind of the mismanagement of low back pain. And I mean, all of his work, right? It was just incredible on everything that he talked about, the kind of over medicalization of back pain and stuff like that. Talk a little bit about that time and kind of what went into that, getting him at that conference, and what were you guys working on as an association back then? What was kind of the focus?
That's a great question, because really the focus of going to Seattle, you got to remember Washington State, had those just dysfunctional laws against, PTs actually moving someone a little quicker. You could move them slowly or maybe this speed, but if you went that speed, that was like illegal, I mean, and just the fear about the term manipulation and was high, and they had fought state chapters, yeomen's work trying to improve the language there, and just hitting brick walls. And so we as association, the academy, said, well, let's go there and go there to that state and be very clear about what we do, and get the students engaged to come and to realize, here they are learning this material, and universities in their own states are saying, well, you can't really do that in our state, or if you do it, it has to be kind of, call it, graded something, but it's frankly, outside the scope. So, I mean, that's the backstory of going to Seattle, and then knowing that Dayo was on the Northwest, and he had commented on a paper we had done early on that was published in Annals, and that John Childs was the lead author on, and he had commented on it, basically saying that manipulation for a subgroup seems to have a slam dunk effect, in his words. So there was reached out to him and said, hey, this is the context, will you come? And he graciously did. It was up the road. So that's how we got him there. And we knew that the purpose was trying to elevate us beyond. I mean, here we were in our trenches fighting, whether this factor was better to use this technique or this factor for this technique. And then on the bigger picture, we're losing the management of back pain, which I still believe first contact provider for low back pain, physical therapist, beyond a doubt, is where it should be. Okay, we don't do it alone, but a first contact needs to be here. If it is first contact, that must include manipulation in your skill set, exercise, and as we know, just great PT skill set of being, caring about the patients that we serve. So I guess that was kind of the backdrop of really that conference, and it was epic. I mean, some great speakers. The party was epic in terms of the Saturday night party too. I mean, a lot of people, livers were hurt that conference. I'm just saying. So
that was good. It was a great conference. You had David Butler, I want to say, and maybe Steve George. It was a fun.
Yes.
That was a fun one. So since then, you have really championed this sort of over medicalization of low back pain and a PT first model, and physical therapists understanding pain, and we've made a lot of strides. I mean, when we look at the literature and what's come out over the past decade, it's exponential how much advancement we've made. What do you think? What are you working on now to continue that fight, and what do you think the future holds?
That's a great question. I think my passion has always been teaching. I love to teach, and I still do. And I really feel like the how we initially are trained to think really changes our trajectory as professionals. And so definitely a passion on entry-level professional education, whether it be PT, educating PAs, other healthcare providers. What we do is a passion. As you mentioned, pain in our podcast, Pain Reframed, it's rekindled a purpose that's bigger than just our profession, that we gotta, it's led by who we are as physical therapists, but we gotta step out into more of a healthcare system perspective and not apologize for anything, and that kind of leadership of who are and what we've been trained to do, and why really our purpose in the here and now. So that would be a passion that I currently have. I mean, it's interesting times. I mean, we're recording this, I think, on the May 14th. So in the last few months, a number, really tens of thousands of people have died from heart disease, from hypertension, from food insecurity. And obesity is really killing us. Unfortunately, we haven't really heard anything about that because of this virus that's been going around called COVID-19 that is serious and is very virulent, so many of us catch it. And yet the most vulnerable among us is those that are going to die. And the most vulnerable are those that, I mean, there are outliers, let's not get on the outliers, but the most vulnerable besides older age is obesity, hypertension, diabetes. Things that are in the wheelhouse of the manual physical therapist. They contact these patients, we move them, we manipulate them, and then we get them out of their pain. But really, I think we personally have dropped the ball in not being more of a coach and saying, okay, we've gotten past, we're literally just at phase 1 of your rehab program. You still have phase 2 and phase 3 because this is your risk score right now in terms of not just this virus, in terms of dying from heart disease and stroke. Yes, I know you're only 40 years old, but do you know that, this is what the trajectory looks like? And if we put you on the TV like we've done everybody else, we would say this is much vaster, larger problem. So I guess my passion now in this current day and time is saying we need to take charge as responsible healthcare professionals to get beyond phase 1 and into phase 2 and phase 3. Phase 1 gets them in the door. And I think if we're all excellent at hands-on skills, pain management, and engaging our patients, we've gotten to phase 1. But we have to not leave that. And we have to say, are we their physical therapist for life? That means we're their healthcare provider for life. I said healthcare provider, not medical provider, because the medical system has made us sick. You know, my opinion on the opioid epidemic caused by the medical industrial complex. These other things are really mismanaged because they're pharmaceutical first. You know, it's farm first versus PT first. And so I guess that's where kind of my passion is. I think this moment in time has shown us just how vulnerable even people that are, you know, relatively younger, you know, if you get hospitalized from COVID, you know, 94 and change percent have at least one risk factor, with the vast majority having several risk factors. Number one being obesity, 65% of those. And so we're seeing, you know, things that we treat, inflammatory disorders, you know, obesity and inflammatory disorder, and just us taking that role. So I think, Eric, that's where I'd say my current, you know, kind of passion is.
Well, we can hear that passion through the screen, and thank you for sharing it. Where do you think, or how do you think our profession needs to get to that phase 2 and phase 3 that you speak of? Like, what are the steps we need to take to get there, especially considering the time we're in?
Well, first and foremost, we're essential healthcare providers. I think like always happens in industries, right? Some folks rose that we are essential service. We have to do things a little differently in this interim phase, but we're essential healthcare providers. That in and of itself is a responsibility, I guess I would say. That means that if you're essential, that means you need to be doing essential things to mitigate risk in your population. So I think the first is like everything, right? It's whether it be a manipulation skill that we used to be, I think in manipulation, many times we were trained to be fearful of that technique. I mean, you're too young, you guys, perhaps in school, but it was like this big deal to do manipulation, right? You know, you had to go through 15-step, well, it was usually a 12-step process after the fact. That's a joke, by the way. No, it was, you had to go through this process in order to learn how to manipulate, which you should, just as you should go through a process to learn how to do competent therapeutic exercise, just as you should to be able to treat other conditions. So in answer to your question, it's really the same model. It has to start with us believing this is our role. We've been talking about this healthcare role, about prevention for a long time in our profession, right? I mean, but we've kind of been narrow in the prevention of the recurrence of back pain, the prevention of the recurrence of your neck pain. And even though we are about preventing, you know, serious health conditions, which have always been our domain, right? Cardiopulmonary rehab, it's been in our domain for forever, you know. Post neurological disorder, we don't leave you at the door. We say, you know, this may be a persistent condition that we need to make you more robust and take you through that disorder. I think where we on the musculoskeletal side have fallen a bit is we, you know, didn't fully engage the holistic mindset, in my opinion. And I think the whole even, you know, regional interdependence concept where we kind of said, hey, parts are actually interrelated was just a nudge to say, you know, well, actually your gut health is related to how you're feeling today. And I don't think we all feel comfortable with those conversations. You know, your gut, it affects your inflammation. It affects, frankly, your immune system. So, you know, what are you eating? You know, and we don't have to be experts in nutrition to ask those questions. Yes, same thing on depression. You know, when we're talking to folks about, you know, where they're at, we don't need to be experts on these disorders. But if we are primary care musculoskeletal providers, we need to have a reasonable competency to know that we can talk about that, and this is within our wheelhouse, and then refer out when it's beyond our wheelhouse. And that referral out may be to other physical therapists first that are more competent than you, or it may be to an acupuncturist, maybe to a nutritionist, maybe to a massage therapist, maybe to a primary care physician, but really we have to kind of make that, we're the trusting person that has to make that decision. Hey, I think you're going to be best suited to go there next, right? Because there's too many choices right now in the healthcare spectrum, and our job is to kind of narrow it down and give the right person to the right patient at the right time.
That's awesome. That's such an exciting trend. I think that we're going to start seeing in our profession, starting to see it now. When we think, Tim, you're an experienced teacher. I mean, I remember thinking, back in the early days of AOMP when you were at Regis, and over the years, you must have learned a lot about what works in the classroom, what doesn't. When it comes to, for those of us that are out there that are teaching, maybe some that are teaching in residency and fellowship training as well, what have you learned? What are you doing differently today? What works well for you as far as teaching and learning?
Yeah, I've learned a lot. I did some, I'm probably did a lot of ineffective teaching during my day. I think, though, there's certain tenets that I was fortunate enough to learn, which when you went to these classes back in the day, I trained more osteopathic model at Michigan State, where they had these 4 and 5 day intensives, and you'd focus on, certain skills literally 8 hours a day, rep after rep, practicing, etc. I think that, coupled with, when I was in the military, this idea that you learned skills through repetition, and they were chunked, they were blocked in how you delivered it. We had a neuromusculoskeletal evaluation course. It was the NMSE course. It was a 2-week course that you basically had to go through to be certified to be a physician extender. And that was way back early in my career. And I learned more in those 2 weeks in musculoskeletal care than I learned my entire, Marquette career and, all my internships, right? In a 2-week block, but it was focused, and it was very much intensive in that you were put together in a group and learning together and thinking about it, sleeping on it, practicing at night. So I'd say number one is that not knowing what language school was about and things of immersion training and immersion learning, I think that's number one, where I now, that's probably the biggest secret sauce of, I think, skill development, where you get immersion learning, not 2 hours here, 2 hours there, 3 hours here and 3 hours there. You're all in. So that's probably number one. Number two is probably, just the ability to have, really skilled people around you. Lab to me, I love teaching lab because labs should be with clinicians who are skilled in their craft and skilled in their passion to impart that craft to others. It is quite foolish if you think about it. And again, we can go on how it got this way due to higher ed and how we had to go down this pathway. But we would probably be alarmed if we had I was learning how to do a total hip, and the person teaching me how to do that total hip hadn't actually done a total hip in the last 10 years or 5 years or 2 years, right? That would seem, I don't want that guy or gal doing the total hip on me, right? In PT programs, we allow that to happen all the time. We allow faculty that that's not their core focus clinically to teach those skills, clinical skills. Knowledge, hey, no problem. I mean, I love teaching outside my area of expertise from a knowledge perspective because I dive in there and, these facts and putting them together into a story. That's a whole different thing. But when it comes to the craft of what we do, that has to be done by people skilled in that craft and with clear understanding and relevance and continuing to do that. And that's why I always say when I quit doing clinical work, it's time to hang up the hat, at least from doing that part of the craft, and I think I can have a fairly long runway because you get better, even if you're just catching a few hours a week, you still have a problem, you still struggle if something's new, and especially if it's getting more challenging case, you get humbled. And I think as long as you continue to get humbled, then I think you can be effective in that type of teaching. So I think those are probably the big ones, Eric, I would say.
Awesome.
So Tim, you talked about the importance of immersion learning and then having skilled clinicians that are passionate about that learning teaching. So can you tell me how your experience is in the 2-year model of hybrid DPT learning and how you feel like that will impact our profession?
Yeah, again, it probably goes back to, early on, because I graduated from an undergrad 4-year Marquette. I mean, you could get in your freshman year. I transferred in my sophomore year. I mean, really, PT school was 2 years. It was, that junior and senior year is really where you focused on the all PT coursework, and then when I went in the Army Baylor program was actually a master's program at the time, but it was only 16 months. Maybe it was, I think it was 16 months, 14 or 16 months at the time. These people had no PT training coming in, and I was looking at their skill set going out, going, man, I am so far behind these. Yeah, they had a master's, but they had, in terms of the actual time doing physical therapy training, they had less time than I had in terms of, calendar months. So that was a wake-up call to the fact that, this immersion model seems to be different. I mean, again, it's hindsight. Looking back, you see that. So to me, we largely built our training on university models, right? US university models, whereby, we have semesters or quarters. We take breaks, during that are on the university calendar, right? You have your winter break. You may be off for 4 weeks, right? From mid-December till mid-January. You may have a 3-week break in the summer. There's more breaks in the program, and the reason is because we built our programs within university models. So that's just how the job gets done. But if you step back and say, what is the most efficient way to learn? At least certain things like language and I believe physical therapy and professional schools, immersion is better. Let's put the fire hose in and let's really dive in and just, breathe. Everything about you breathe this new profession, because literally that's what you're trying to do. You're trying to create someone that's very different. Not skills, very different in who they are as a human being and their purpose. And I think that's better when you're kind of forced into, communities of that have to struggle together. And I think all PT programs have a bit of that, right? I mean, you have challenging times, which forges you as a team. So I don't think it's really that different. 2 years doesn't seem, having taught in, Army Baylor model and at Regis, at Rocky Mountain, and now it's South, to me, it doesn't seem, yes, it's accelerated, but it's because it was built from the ground up, the parts integrate better. It's so hard to retrofit things. That's why, people are struggling. Like right now, I can't imagine having to pivot to online learning, and kudos to all of my colleagues that, our colleagues that are having to do that. I mean, it's just, that's just really hard to picture how that is. So I guess that would be my big thing, that you don't have to, that the shift hasn't been that difficult, if you will.
So it's really exciting to think about kind of these more efficient models and this contemporary model of education. Earlier, you talked about primary care and sort of holistic care. Are you bringing that into the classroom at all now? And where do you think that we are headed in regards to entry-level DPT education in that realm?
Yeah, that's a great quote, Eric. And again, you look at, whenever you add material, you have to let stuff go. And then you have the darn national board exam that's behind the times that you're like, oh, by the way, we have to teach you how to pass a test that may not be relevant. Now, we know it's relevant, I guess this is being videoed. Well, some of it is not relevant. I can say that. I mean, it just, because it's not the way it's designed, right? It's designed such that what's happening in the clinic, and it's designed as a safety test. It's not designed as contemporary practice and where you're going as a profession test. So, they serve different purposes. And I think that's the struggle all academic faculty have. I mean, trying to keep that balance of where we're going with, what's occurred in the past. So, if we can cleave off some of the stuff that really is not as relevant, and really focus on, I believe we are in this holistic profession, and the new tribe of healthcare providers will be people that are in functional medicine, that are in lifestyle medicine, that are doing those types of things. And so we can't become experts on that, but we at least need to have our students embody that personally, right? So that means us modeling that as faculty. That means throughout, from the minute they step into the program, they're doing mindfulness personally, mindfulness training, whether it be some type of exercise program, sleep, hygiene, nutrition, following, heart rate variability, looking at, so looking at personally all these variables that predict good health, and then just thread that through the curriculum, so they then kind of just embody that as individuals. And I think then that makes it easier to talk the talk. And clearly our continuing education and certifications, I think we're going to see more and more, where I would like healthcare tracks, and there's some of these out there, but I'd like to see more where we quickly, PTs get for what they know, what their knowledge base, credit for, and into these more functional medicine tracks and certifications, so that they feel confident to sell that surface. You don't need to have those to talk about nutrition, sleep, gut biome. You don't need to have those certifications, but I think we all learn and feel better and would feel more confident selling those services as we go on into a profession. But so I just think we're going to see a spread back out to some of those areas. I hope, anyway.
And one final question to build off of that, Tim, would be, how do we help influence our fellow clinicians that don't take that personal pride in health, in embodying health and wellness? How do we spur that on just in our surrounding community?
It's a really fundamental question. And I think if you look at, the idea of how the tribes that we hang with, or the communities that we hang with, we tend to become more like them, right? So if we're around smokers, we tend to smoke more. If we're around people that don't eat healthy and are gaining weight, we tend to gain weight along with them. If we hang out with people that are eating well, exercising, talking about, interesting health stuff, we tend to go that way. So I think it always starts with leading by example in your space that you're able to, right? Because if we make an influence in our clinic, and you all know that, you may have a clinic where it has one kind of vibe, and then you get one passionate therapist that goes in there and kind of shifts the whole vibe, of how things happen, and they start doing things that, first people are looking at them like, why are you doing that? And then all of a sudden, they're the ones that their schedules are always full and patients are raving about them. They're like, can you show me that? That kind of. So I think that it starts there. And then I think as we gain so start locally, and then really build upon it with our networks that we can use now that we have social networks that allow us, if we feel isolated, to find colleagues like ourselves that, hey, you can bring in so you don't get burned out, that you don't feel like you're just pushing this rock up the hill and you're the only one doing it. And I think we're way better able to do that now. So I'm actually very positive that our change can happen quicker than it has in the past.
Thank you. That's a really refreshing perspective. I'm glad that you're in my tribe.
Well, Tim, thank you so much for joining us today. We really appreciate it. You have just been such a wonderful representative of AOMPT, and I think that we all really, really appreciate having you on our team, like Lindsay just said, and thank you for everything you do for our profession.
Well, thank you guys for doing this, and I love these kind of things, and I know that it takes effort and time to do these things, so really appreciate all you guys do and getting the message out. And I'm glad we're part of the same team, and it's just fun to be with you guys, and thanks for having me this morning.
Thanks, Tim.